The three family medicine employment models, and the single question that defines your leverage before you sign. Before you evaluate a single compensation number in a family medicine contract, you need to identify which of three structural models you are entering. The model determines what every clause means, who controls the subsidy, and how much renegotiation leverage you will have in year 3. Model 1. The hospital-employed practice. This is the most common structure for new family medicine physicians. The hospital or health system owns the practice, employs you directly, and absorbs the operating loss that outpatient primary care generates. Compensation is typically base-heavy. The 2025 National Family Medicine data shows that the median straight salary allocation for family medicine without obstetrics is 67%, meaning 2/3 of a typical compensation package is fixed. The hospital subsidizes the practice because primary care panels generate downstream revenue, specialist referrals, imaging, surgery, and emergency visits that flow through the health system. That downstream revenue does not appear in your contract. The subsidy that keeps the practice open does not appear in your contract either. Model 2. The independent or physician-owned group. These practices operate outside a hospital system. Compensation is more production-linked. The same 2025 data shows a quarter of family medicine physicians operate on contracts where 0% is base salary, meaning pure production. These practices cannot absorb operating losses from a system balance sheet. What you collect is closer to what you earn, which creates more direct alignment between your clinical volume and your income. The trade-off is exposure. If the panel is thin, the revenue is thin, and the comp follows. Model 3. The Federally Qualified Health Center, the FQHC. These are federal grant-funded community health centers, required by statute to serve patients regardless of ability to pay. Compensation at FQHCs is typically salaried, disconnected from production, and funded in part through federal grants and enhanced Medicaid reimbursement rates. The 2025 National Family Medicine data shows academic and community health-aligned positions have a significantly different compensation structure from private practice, with the academic and federally funded segment paying $231,268 at the median, compared to $311,557 for community family medicine incumbents. That $80,289 gap is the structural cost of mission-driven practice settings. Now the single question. When you receive an offer, ask, who absorbs the operating loss if the practice runs below break-even? If the answer is the hospital system, you are in Model 1, and the downstream revenue argument gives you leverage. If the answer is the physicians themselves, you are in Model 2, and panel growth and visit volume are your leverage. If the answer is federal grants and enhanced reimbursement, you are in Model 3, and the comp ceiling is set by the funding structure, not negotiation. The compensation number in the offer letter is real. The structure that determines whether that number can grow is the answer to that one question. Run your contract through ClauseLine at ClauseLine.com.